presentation. A 48-year-old woman was admitted to the ICU with fatigue, shortness of breath on exertion, weakness, palpitations, and a cough from pulmonary congestion, okay? She had bacterial endocarditis 15 years ago, okay? Upon auscultation, she has crackles throughout, okay? We have a heart rate of 125, high, low, or normal? High, good, excellent. Respiratory of 40, high, low, or normal? High, okay. We have a blood pressure 90/45 with a MAP of 60. I see Hayden push going down, low, okay. We're concerned about that. A temp of 37 degrees Celsius, fine, right, normothermic. And then a SAT of 86% on room air, okay. Are we concerned about that?
Yeah.
Okay, what in the interim, before you even move on, what do you want to do for this patient? Okay, airway, you're concerned about that, excellent. And so, do we just leave them on 86%? No. Okay, can you put them on oxygen? Do you need a doctor's order for that? Is oxygen a drug?
Yes.
Yes. Okay, absolutely. Oftentimes, in the ICU, we have care sets that are initiated, okay? Oxygen, you guys, is an order. It's a medication, okay? You need a physician's order. You can't willy-nilly just throw someone off, okay? You need a doctor's order. Oftentimes, we have a built-in care set that says, I can put this person on a nasal cannula for a SAP greater, keeping it greater than 95%, okay? So just know that I don't want to leave her like that. Okay, she's setting that 86. We want to do something about it. Okay, so real quick, those of you guys that came in, okay, this patient's presenting with fatigue, shortness of breath, on exertion. Okay, so what does that mean when I say on exertion? So she's walking, and she's like, whoo, I can't breathe. She climbs up the stairs from the second floor on the library, and she has to rest, and she's out of breath. Okay, she's breathing fast. Palpitations, weakness. She has a cough from pulmonary congestion, okay? And then lo and behold, your assessment matches that. When you listen to her lungs, she has crackles throughout, okay? And then ding, 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 big clue, she had bacterial endocarditis 15 years ago. Okay, so given this presentation, what do we think is happening? What do you think? Oh, I forgot a C on there, whoops. Okay, so what do you think diagnostics? Okay, we have a lot to discuss in this small little slide. You can do it. So what do you think's going on? The big clue, you guys, is that bacterial endocarditis. So remember, she had those airstream vegetations on some valve. Looking at her presentation, what valve do you think is involved? What do you think? Now she has a valve problem. Okay, which valve do you think it is? Look at her presentation, okay? First and foremost, break it down, right? Is it the right side or the left side? The right valves or the left valves? Careful. So when I say right side valves, I mean tricuspid and pulmonary, okay? I'm going to clue you in right now, it's not those. Okay, left side, mitral and aortic. Yay for you, I only am going to test you and you only need to know mitral and aortic. Okay, left side. Okay, yay for you. Only mitral and aortic is what you need to know, but this is a specific type. You guys can talk. Talk amongst your friends here. Nursing's a team sport. What do you think it is? Look at the symptomology. This is when you might absolutely need to bust open your textbook and look. let's talk about this. Okay, so which side of the heart has higher pressure, right side or left side? Left side, okay? Left side has higher pressure. Why? Because the left side is responsible for pumping heart out to the rest of the body, right? So again, oftentimes you'll see more valvular problems, heart disease with valvular problems, right, on the left side. Why? Because it's a higher pressure system, okay? That's why I want everybody to focus on the mitral and aortic, okay? Now the big clue that we saw in that patient presentation is that she had bacterial endocarditis, right? So she had some sort of vegetation on her valves 15 years ago, okay? So oftentimes, valve disorders are caused by a couple different things, 3 things, okay? Usually it's caused by degenerative disease. What do I mean by degenerative? Age, absolutely, so time, right? So time, lifestyle, right? You can wear down the valves that way, okay? Rheumatic fever is another huge thing that can cause valvular disease, okay? And then last but not least, our most favorite thing that we've talked about thus far today is infective endocarditis, okay? Those 3 things can compromise someone's valves, okay? Now there's 2 types of compromise that we talked about, okay? There's 2 types. So you have what's called stenosis, okay? Stenosis is where there is a narrowing of the valve, okay? So think about the difference between a straw and a PVC pipe. What's easier to pump blood through? The PVC pipe, right? When you have stenosis on the valve, the valve becomes like a straw, where it's very hard to pump blood through, okay? Pressure builds. Pressure builds depending on which valve this is, okay? The other thing that could happen, right, is insufficiency or regurgitation. Okay, that's where the valve leaflets don't close properly and there's a backward flow of blood. Okay, there's a backward flow of blood. So in talking about our patient presentation, right, there's a lot going on here. There's weakness, there's shortness of breath, right? What would you say a lot of these symptoms have to do with? What organ do you think they have a lot to do with besides the heart? The lungs, right? The lungs. So that being said, we can rule out right there the aortic. It's not the aortic valve we're talking about. We're talking about the mitral valve, okay? Now the mitral valve, you're trying to think, is it stenosis or is it regurgitation? Stenosis or regurgitation. The big thing, right, the big thing that we see here is crackles. Crackles and that cough and pulmonary congestion, okay? Now, usually, mitral regurgitation is associated with pulmonary edema, okay? Pulmonary edema, which is what those crackles are, okay? Palpitations. I'm sure if you were to auscultate the heart, you would maybe hear a murmur. Now, conversely, okay, we did talk about that she has some shortness of breath on exertion. Usually, in an acute setting, that's the first sign of mitral stenosis. So really, she could have a mixed picture. I know, that's throwing a monkey wrench in what you want to know, but just know that sometimes it can be a mixed picture. She probably has more regurg than stenosis, but she might have both from her symptomology, okay? We know that it has to do with her mitral valve. We know that there's a lot of regurg happening. Why? Because she has that pulmonary edema and those crackles, okay? But with stenosis, usually the first sign that says someone has mitral stenosis is dyspnea on exertion, that shortness of breath on exertion. They climb the stairs suddenly and they're out of breath. And they're like, that's weird, that didn't happen yesterday. Okay, so usually that's the first sign. But her, she can have a mixed picture, but with her, we're saying that it's mitral regurgitation. Okay, why? Because she has that significant pulmonary congestion, crackles, that cough, okay, because it's backing up, that blood flow is backing up into the heart, okay? Now globally, what I want you to think about is that when you have valve problems, there is blood flow issues, okay, blood flow issues. And globally, if we have blood flow issues, right, where the heart isn't able to pump effectively, what can that lead to? If the heart can't pump effectively, what can that lead to? Low cardiac output. Okay, great. I love it. What else? If you have a lot of pressure building up, okay, a lot of pressure building up with this mitral regurg, okay, and you have, where is the mitral valve? In between the atrium and the ventricle, right? So you have blood backing up into the atrium, okay? You have a lot of pressure, okay, in there. Is the heart able to pump effectively? Is it going to try harder to pump more effectively? Absolutely. Is working harder sometimes good for your heart muscle? No. So it can lead to what? Heart failure. Exactly. So all of the valvular problems that you will look at can all lead to heart failure. You need to be thinking about that, okay? So in medical management, right, we see that oftentimes, okay, well first, how would you diagnose this? You can get a chest x-ray, okay? That's gonna show that the heart's larger, right? That's not the best picture. Usually it's an echocardiogram. An echocardiogram is gonna give you the best picture, the size of all 4 cardiac chambers, okay? It's gonna tell you if there's any sort of hypertrophy, okay? If any of the cardiac chambers are dilated. It's going to show you specific valve dysfunction. It's going to give you the EF, for example, okay? And then it's also going to tell you the amount of regurgitation that the patient has. The echocardiogram is key. We want the echocardiogram as our diagnostic tool. Now, which one is more invasive? The TTE or the TEE? TEE, transesophageal echocardiogram. The invasive one has esophagus in it, right guys? Because your esophagus is inside your body, right? Inside your body, more invasive. Put a scope down your esophagus. The transthoracic is on top of your chest, okay? Okay, so diagnostically, we talked about that, okay? And then what are we gonna do? Oftentimes, yes, ma'am.
I have a question. I know usually we say, oh, to first do least invasive and then go to invasive. But in the critical care setting, should we just assume to go invasive first to get more accurate?
Are you talking about in terms of an echo?
Just
or
like
anything
in general.
So it depends. So if you think about like an echo, for example, just like nailing this on the head, you have to like have the right people to do that, right? You have to have a cardiologist to do, you have to have the right equipment. You have to sedate the patient, right? You have to get consent. That is a lot of steps to be able to get that diagnostic test. Whereas a transthoracic, the person with the little ultrasound machine can just come on up and do it. And it's super quick. You don't have to sedate your patient. And oftentimes they'll start with that. Maybe they won't get a clear picture and then they may have to do a more invasive one. But oftentimes they want something right now. The patient is in distress. We want diagnostics right now, so they may do a TT, a transthoracic echocardiogram first, okay? Oftentimes, adipose tissue is a big factor, right? They can't see everything that they want to see, so then they may need to go more invasive. Good question. Okay, so I know it's like you want the cookbook, right? You want A plus B equals C. It just kind of depends on what's happening, okay? Yes, every circumstance and situation is a little bit different, okay? So in terms of medical management, oftentimes when people are coming in, you are seeing them have symptoms of heart failure, okay? You see someone have symptoms of heart failure. The crux, the problem, the etiology behind that heart failure is a valve problem, okay? So the management, right, before we can solve it, oftentimes it's a surgical intervention that happens. You want to maintain homeostasis. What I mean by that is you want to maintain good cardiac output. And that's very similar to the treatment that you would see for heart failure, right? What do I mean by that? Well, you want to maintain cardiac output, right? You want to maintain cardiac output. What's one drug I could start right now to help maintain cardiac output? Help that pump, effectively pump more better. More better. Better. What? An inotrope. Like what? Dobutamine, absolutely. So you can start some dobutamine in the meantime. You know that your patient is going to buy themselves a trip to the OR. because we can't just leave them like this. But in the meantime, while you're getting all the players for that OR, you start them on Dobutamine, okay? That's helping the heart contract more effectively. Okay, now the next thing is you want to decrease preload, decrease afterload, right? You want to make sure that you are decreasing the volume. You don't want your patient to be fluid overload, right? Because again, if things are backing up into the lungs, where else are they backing up? They could be backing up into the heart, or excuse me, into the rest of the body as well. So you want to decrease preload. How can I do that? Diuretic, absolutely. Okay, so maybe start some Lasix. Okay, what about decrease afterload? What might they be on? Vasodilator. Okay, so with her, do I want to start her on a vasodilator? No, right? So again, look at the patient, make it make sense. She actually might need a vasopressor to help with blood pressure, okay? Why? Because her cardiac output is so compromised, right? We know that the cardiac output is directly correlated to blood pressure, okay? So she probably has been like this for a while. She's probably been like this for a while, and now we're heading towards that picture that we'll talk about next week, cardiogenic shock, okay? So again, look at your patient. It's not an automatic thing, you guys. Well, you said, Professor Bloor, I need to decrease afterload. She's already doing that. She's already doing that, and we don't have a good map, so I might need to start a vasopressor. Yes, I still want to decrease preload because my CVP is, what do you think it is? If I'm fluid overload, what do you think my CVP is? It's going to be high. Okay, well, how high?
9.
Okay, or more. How about 2025? Okay, 2025. Everything's backing up into the lungs, right? So I need to decrease that preload. I'm not going to start a vasodilator because I don't want to drop her blood pressure even more. Okay, so look at the patient. Does it make sense? Now, I can manage someone, right? I want to make sure that I'm optimizing their oxygenation, right? So she's on a nasal cannula, okay? So I'm making sure that her sats are increased. I'm checking an EVG to make sure that oxygenation is great, because at this point, my cardiac output is not doing well, right? My cardiac output is not doing well. So, surgical intervention, we know that this person is either going to go and get a repair or a replacement, okay? So a repair is where they go in and they fix the current valve, okay? I would suspect with her history of bacterial endocarditis, her valve will probably need to be replaced, okay? We're beyond the repair, we need replaced, okay? So with the replacement, there's 2 different routes you can have. What are they? 2 different routes with replacement. Oh my gosh, I'm asking a lot of questions. Oh my gosh, I might need to open the book, right? Yikes. With replacement, there's 2 different avenues that one can get. What do you think? Mechanical or? Yes, exactly, an animal, so biological, okay? So now this lady, she's 48. What do you think she should have? Should she have a biological or mechanical? What lasts longer? Mechanical. Okay, perfect. With the mechanical, what do you need to be worried about so it doesn't clot up? What medication do they need to be on for that? An anticoagulant, exactly. Okay. So with a mechanical valve, you need to have lifetime anticoagulation. Okay. Oftentimes we maybe start them on a heparin drip, but they're gonna go home on Coumadin. Usually the INR goal that we have, INR, we use that to be able to titrate the Coumadin, is usually 2.5 to 3, okay? We don't want that mechanical valve to clot up, absolutely not. It's actually cool if you can listen to someone, you hear the clicking. Yeah. It's very cool. So mechanical valve lasts longer. There's higher risk though, right? So let's say that this lady is 80 and you start her on Coumadin. What's she at risk for? Bleeding, okay. If you have an 80-year-old and she's at home and she lives by herself, what's she at risk for? Falls, yes. Do we need to be worried about this patient that's 80-year-old that she has a mechanical valve and she's on anticoagulation? Yeah, she can fall and hit her head and then have a head bleed, okay? Let's look at a different scenario. scenario. What about if this lady was 28? She's 28, what kind of valve do you think she should get? Specifically a woman, and she's 28. What kind of valve do you think? Okay, biological what?
Because if you want to get pregnant.
Yes, excellent, good job, perfect. So these are the things that you need to be thinking about and talking to your patient about. Okay, you and the collaborative interdisciplinary team, it's not just you, right? But you have to look at it. This person, 48-year-old, she's beyond childbirth. She doesn't have to worry about that. I mean, theoretically, I guess she can, people are having kids a lot later. But again, that 28-year-old, you might want her to have a biological. Yes, it's not going to last as long, but if she wants to have kids, she cannot have kids on with a mechanical valve on anticoagulation. Okay, so if she wants that option, you're gonna want her to have a biological one. Okay, does that make sense? Do you understand the difference? You guys need to know this. Spend some time looking at the surgical interventions for valvular disease, repair and replacement. Okay, and the difference between biological and mechanical. You have to go over this. Okay, hint, hint. Okay, questions about this? No? You guys good? All right, let's do some questions.
What do you want to add? Professor, could you repeat what you just said about what we should look into about the valves?
Valves, yes. So valves need to know mitral versus aortic, the left side of the heart, and I want you to look into the surgical procedures, the difference between repair and replacement. And when you're looking at replacement, I want you to understand the difference between biological and mechanical. Who is best for what? Okay? Now, in anticoagulation, okay, this is one of my pet peeves, okay? We just talked about anticoagulation for valves, and I threw out the situation Coumadin, okay? Coumadin, and then prior to that, I talked about heparin, which is an antithrombin, right? Okay, even if you're like, I don't know what that means, it's a type, that's what it does on the coagulation cascade. Do I want you to know that about the coagulation cascade? No, I don't want your heads to spin. But I need you to understand that anticoagulants are different than antiplatelets, okay? What is an example of an antiplatelet? Aspirin, okay? Does aspirin thin your blood?
No.
No. No, no, no. I know, everyone, you're like, what? What are you talking about? That's what I've learned. Aspirin equals blood thinner. I'm sorry, it doesn't, okay? I'm sorry, it doesn't. You're in block 4, you can understand the pharmacokinetics of something. Aspirin is an antiplatelet. How I think about, so you know that Pam, you know when you cook, you spray Pam or like olive oil or whatever, so things don't stick to the pan, or the pan, wow. Pan, there's a lot of stuff going on. Okay, I want you to think of an antiplatelet like that. It's like Teflon, okay? They slide by each other. An antiplatelet prevents clumping. Okay, it prevents clumping. So platelets that aggregate, okay, right? So we talked about endocarditis. We talked about that a clot forms. Part of that clot, you better believe, are platelets, okay? If that person is on aspirin, it prevents that. The platelets slide by. They're like, la la la, they slide by each other, okay? Now if they're not on aspirin, they're gonna clump together like you guys on your tables. It is not a blood thinner, okay? Coumadin, heparin, bivalirudin, all blood thinners. They interact in the coagulation cascade to thin someone's blood. None of those that I mentioned are clot busters. TPA, alteplase, is a clot buster, okay? Now we use TNK a lot of the times. I can't remember what it stands for, but TNK is like the abbreviated version of it, okay? Do you understand the difference, okay? When we get to ACS, you're going to need to know that, okay? But especially for valves, if you pick aspirin on the test, I'm gonna be really upset, okay? I'm gonna not give that answer back to you because I just spent 5 minutes talking about it, okay? So do not pick that. Please, 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 okay? Okay, so a new client newly admitted to the telemetry unit is experiencing progressive fatigue, hemoptysis, and dyspnea. Diagnostic testing has revealed that these signs and symptoms are attributable, wow, that's a hard word to say, to pulmonary venous hypertension. Which valvular disorder would the nurse anticipate being diagnosed in this patient? What do we think? Stenosis, okay? We have, again, a lot of things having to do with the lungs, you guys. Hemoptysis, dyspnea, pulmonary venous hypertension, right? So we have that stenosis, and pressure is building up in the left atrium and causing things to back up in the lungs. Okay, so they can't breathe. Remember, the first sign or symptom of mitral stenosis is dyspnea on exertion. Okay, dyspnea on exertion. Thank goodness you don't need to know mitral prolapse, just skip that for right now, okay? Even though someone said it's common, but whatever. Okay, and then it's not that we're not talking about aortic regurgitation or stenosis. Okay, we haven't talked about any sort of syncope or anything, any of the signs and symptoms that one would get with an aortic disruption. Okay. All right, let's talk about this. The healthcare provider has scheduled a client with mitral stenosis for a mitral valve replacement, either biological or mechanical. What condition will the nurse expect to see as a complication of mitral stenosis? Okay, so again, mitral stenosis, right? We talk about the narrowing of that valve, and we have that pressure. Pressure is building up in that left atrium, okay? And so we know that it can lead to pulmonary hypertension. What's behind that atrium? The lungs, right? So we know that that stenosis can lead to a pressure in the lungs, okay? Does that make sense? Okay. More seconds, you guys. staff educators presenting a workshop on valvular disorders. When discussing the pathophys of aortic regurgitation, the educator describes what consequence of this order. Okay, what do we think? Left ventricular hypertrophy, okay? Hypertrophy, whatever, okay? So again, think about it, right? Aortic regurgitation. Blood is backing up into the ventricle, right? Blood is backing up into the ventricle, and that's causing the left ventricle to dilate, okay? And it's causing the cardiac output, oh, I'm gonna die, I gotta move this, I'll move it later. It's causing the left ventricle to work a lot harder, right? It's causing the left ventricle to work a lot harder because of that regurgitation. Blood is not going where it should, right? And we want the heart to pump effectively. It is not pumping effectively with this aortic regurgitation, okay? Remember, regurgitation is the backward flow of blood, okay? Does that make sense? Yes? Okay. Valves are hard, I know that. Valves are hard, so spend some time on it, okay? Mitral and aortic, okay? I like this question. This is a good question. Time to exit the scene. That was someone's alarm. 30 seconds, guys. Oh, good job. Excellent. You guys ready to talk about it? Okay, a nurse is assessing a patient who has had valvular heart disease for more than 15 years. Okay, so their valves, the blood flow in the heart has not been working great for 15 years. Okay, so it's a chronic condition. What signs and symptoms should the nurse expect? Okay, so we should have picked, right, paroxysmal nocturnal dyspnea. They have trouble breathing at night, right? They probably have to sleep in a recliner because they need to sit up. Orthopnea, right? Positionally, they have a trouble breathing. Oh, that's weird. 2 different breathing things, huh? Oh, and the last one, a cough, okay? So what are all of these things have in common? What are these things telling you? With that chronic condition of having valvular disease for 15 years. What are those signs and symptoms describing?
Complications of the lung.
Okay, perfect. But what is that saying about the heart? So what complication of valvular disease do you think that this person's developed? Okay, sure, they could have regurgitation. We don't know what kind of problem they have, either stenosis or regurgitation. But what are those signs and symptoms usually indicative of? They have trouble breathing.
Pulmonary hypertension.
Okay, pulmonary hypertension, absolutely, that could be it for sure, okay? But globally, if you look at the patient and they've had these valve problems for 15 years, it's a long time, okay? 15 years, the heart has had to work extra hard because things are, you're pumping blood through a straw, things are flowing backward. So what did that lead to your heart? Do you think that person's heart is in optimal condition? No, right? So what do we think is going on with this patient? Heart failure, yes. All of these symptoms, orthopnea, paroxysmal nocturnal dyspnea, a cough, right? Those are all signs and symptoms of what type of heart failure? Left-sided, right? Left-sided heart failure, okay? So this person, again, our clue, right, guys? We've had a chronic problem for 15 years. That's a long time. Remember, we talked about valves. It's a problem with blood flow, okay? And if this patient has had this problem, they hadn't had any sort of repair or replacement, right? They've just been dealing with it. We can think that this patient has heart failure. Now, if I were to send a lab to help me diagnose heart failure, what would that lab be? BNP, excellent, good job. So BNP is probably going to be elevated. Why? Because they have signs of heart failure. Okay, left-sided heart failure, does that make sense? BNP, B as in boy, N as in Nancy, P as in Paul. Brain natriuretic peptide. That is the lab used to diagnose heart failure. Okay, let me say that again. BNP, brain natriuretic peptide, is used to diagnose heart failure. So someone that's presenting with this valvular heart disease, again, chicken and egg, right? The chicken is the valvular disease. Now we have heart failure, okay? What caused it? The valvular disease. How do I know? Well, this patient's presenting with all these symptoms. The lab I want to send is a BNP, okay? Questions? Okay. Oh, look at that. Talking about heart failure. Excellent. Maybe 30 more seconds, then we'll talk about it. All right, which of the following patients are most at risk for developing heart failure? So what do you think? Do you think a 69-year-old male with history of alcohol abuse and recovering from an MI?
Yes.
Absolutely, right? You have something that happened to the heart. 100%, they're at high risk for heart failure. 55-year-old female with a health history of asthma and hypoparathyroidism. Nope, nothing. Lungs and then some sort of endocrine disorder, right? A 30-year-old with a male history, of endocarditis and severe mitral stenosis. We just talked about this, right? Any type of valve disorder, they're at high risk for developing heart failure, okay? And he has severe mitral stenosis. 45-year-old female with lung cancer, negative, okay? And then a 58-year-old female with uncontrolled hypertension is being treated for influenza. Yes. Why is that? Well, Professor Blur, she has the flu. Why do I care about that?
The hypertension.
Hypertension, right? Uncontrolled hypertension, right? Anything that the heart has to overcome, right? So if you have high blood pressure, the heart has to overcome that resistance to push blood into the rest of the body. Okay, that is going to lead to heart failure if it's never controlled. Okay, yes ma'am.
Would she still be at risk if it were controlled hypertension?
I think that controlled, anybody that has a history of hypertension could, but controlled lessens your risk significantly. Okay, it's all about that compliance. Great question. Okay, almost done. Don't worry, we got this. All right, let's talk about this. So, patient is diagnosed with left-sided systolic dysfunction heart failure. Which of the following are expected findings with this condition? So do we think that his EF is going to be less than normal?
Yes.
Less than 60%, yep. But down here we have this other thing that puts it, so it should be A. Is a heart cath shows an ejection of 65% left-sided heart failure. Negative, Ghost Rider. Why? Because 65% is great. It's normal. Anything above 60. Patient has frequent episodes of nocturnal paroxysmal dyspnea. They can't breathe when they're laying down trying to sleep. So the answer is both A and C. Both symptoms are, or both, excuse me, diagnostics as well as symptoms are indicative of heart failure, left-sided. Good job. It's a great question. I love this question. All right, let's talk about this. A patient is being discharged home after hospitalization of left ventricular systolic dysfunction. As the nurse providing discharge teaching to the patient, which statement is not as capitalized, a correct statement about this condition? So you're looking at for the wrong one. Signs and symptoms of this type of heart failure can include dyspnea, persistent cough, difficulty breathing while laying down, and weight gain. Is that all things that are true for left-sided systolic dysfunction? Yes, absolutely. It is important to monitor your daily weights, fluid, and salt intake. Is that true for left-sided heart failure? Yes. Absolutely. Left-sided heart failure can lead to right-sided heart failure if left untreated. Is that true? Yes. Absolutely. You better believe that it can lead to global heart failure. And then last but not least, this type of heart failure can build up pressure in the hepatic veins and cause them to become congested with fluid, which leads to peripheral edema. Which type of heart failure is that describing? Right side, exactly. So you must, again, review the difference between right-sided and left-sided, okay? Last but not least, let's do this question, and we'll take a 5-minute break. We are right on schedule, everyone. Couldn't be happier.
Can I ask a question?
Yep.
On one of your quizzes, there was a question similar to that that was asking like how to measure fluid status, and there was daily weights and intake and output,
Okay.
or urine and output.
Okay.
And, like up to now, I would have thought daily weights because that was like your most accurate.
Sure.
It was urine output.
Yeah.
Intake and output.
Yeah. Urine output is the most accurate reading of your fluid status. I know you thought it was daily weights probably up until that, but now in the critical care world, it's urine output. Urine output is the most accurate reading of your fluid status. What?
Previous block has been drilled, and I feel like since block 1, it's been daily weights, daily weights, daily weights, daily weights, daily weights.
Yeah, critical care we up the ante a little bit.
So
Urine is king. Yep, absolutely. Urine output knows that you are hydrated. If you have urine output, the interventions that you did, whether you are hydrating your patient or diuresing them, it tells you if it works. The daily weight might not do that because oftentimes the daily weight, it takes a couple of days for things to catch up to you, so it's not the most accurate. Okay. All right, let's talk about it, you guys. So, patients with heart failure can experience episodes of exacerbation. All the patients below have a history of heart failure. Which of the following patients are at most risk for heart failure exacerbation? Right? So exacerbation means that they were compliant, things were golden. It doesn't necessarily fix heart failure unless you get a heart transplant, right? But you can make things manageable. And exacerbation means that It's not manageable. Things have gone awry. They partied for the weekend and they didn't take any of their meds, okay? So which of the following patients are most at risk for that? A 55-year-old female who limits sodium and fluid intake regularly. No, she's great. She's managing everything beautifully, okay? A 73-year-old male who reports not taking amiodarone for 1 month, why we're not sure, and is experiencing AFib. Is he most at risk? 100%, right? He just doesn't want to take his amiodarone. Doesn't make any sense to me. A 67-year-old female is being discharged home from heart valve replacement surgery. So again, you guys, she fixed the problem. She fixed her problem. She got heart valve replacement surgery, okay? And then a patient who has health history of eczema and cystic fibrosis, nothing to do with cardiac, okay? Questions about that? Okay, let's take a 5-minute break. Okay, well, a little bit longer. Come back at 12:20, and we're gonna start on our last Nearpod. We got this, okay? 7 minutes, 12:20, you guys.